Hi, my name's Rachel Matthews, Senior Respiratory Physiotherapist here at the James Paget Trust. This physio is to assist with the teaching of oral and nasal pharyngeal suctioning of the spontaneously breathing patient with the aim of clearing secretions. Usually we may have gone through a hierarchy of other treatment techniques such as ACBT, the active cycle of breathing technique, where we get patients to take nice big deep breaths in, to huff and have a nice strong cough to help with their secretion clearance. It may be that we've got them up and moving around and mobilising to help clear their secretions. Sometimes positioning can work, whether lying the patient flat on a head down tilt or lying them on their left or their right side to help drain secretions and let gravity assist. We may have also gone through techniques such as percussioning, some shaking and some vibrations to help move the secretions higher up the airways. If the patient isn't able to cough and clear them themselves, it may be that the cough assist machine can help, but the patient does need to be able to coordinate and cooperate with the machine as well. If not, we come to the oral suctioning. Oral suctioning is not considered an AGP, so we're fine wearing our surgical masks. When it does come to the nasal pharyngeal suction or deep suctioning, that is classified as an AGP, and so your full FFP3 masks, goggles, visor, and your full gown and gloves and apron should be required. With the oral suction, you do need your wall-mounted or your portable suction unit. I have here the wall-mounted suction unit with its gauge. Pressure should be around 16 to 20 kilopascals. You obviously want to check that the unit is working by turning it on and occluding the end of the suction tubing just to check that you feel the pressure and that the dial oscillates around. With any technique, you're obviously going to wear your full PPE which is required, whether that's for the oral suction or the nasal suction. With oral suction, you'll use your yanker, which are normally behind each bed space. Attach it to your suction tubing, and you should only ever suction what you can see in the mouth. It may be that having a tongue depressor from the mouth care kit can just help keep the tongue down and help you get a nice clear view. Obviously bear in mind wearing a visor or goggles in this situation. If that isn't enough to help clear the secretions from the patient, then we can progress to the nasal pharyngeal suction. Airways can be inserted. You measure from the nose to the ear, and you insert at 90 degrees and insert straight down. It won't go in on this model, unfortunately, but that's your nasal airway to help you suction through. You will also have your suction catheters. There are 3 different sizes that we have in the trust. They are colour coordinated. You'll get black, which is a size 10, the white, which is a size 12, and the green, that is a size 14. For nasal suctioning, I would normally opt for the black, the size 10, the smallest one. You will also require some lubrication as well to make it more comfortable for the patient. It is an aseptic non-touch technique, so you will need to use a clean glove over your normal gloves. What I'd often do is just have a glove ready and open the lubrication on that clean glove from the tubing. You'll have your suction tubing and your suction catheter. Open up the suction catheter and insert onto the tubing. Remember, this is a non-touch technique. Ideally, we don't want to be touching that sterile suction catheter with our dirty gloves, so we'd go and get a fresh glove to pop on top. That clean glove can then touch your suction tubing and we can discard the wrapper. A little bit of lubrication just on the end. And then ideally you want to look at which nostril may look slightly bigger. They often say the right one, but it may be very dependent on your patient. Neck positioning can be useful as well. Obviously, if your patient is slightly more upright in bed, you still want the head tilted back. Sometimes tilted to the side as well can just help. It prevents the patient swallowing the tube, which would obviously go nasogastric, which we don't want. We're going nasopharyngeal. So you have your sterile suction catheter, you're going to insert it into the nostril. You'll often then find that firm end point. It's a case of pushing through that, and that will then come down to the back of the mouth. If the patient is alert enough and able to, if they can have a cough, that will just aid the movement of the suction catheter in the right direction. Obviously, when you insert a nasogastric tube, you want the patient to swallow. With the nasopharyngeal tube, you don't want that swallowing. You can ask the patient to stick their tongue out. Very difficult to swallow when your tongue is stuck out, so that can help. So then you're going to insert it in the next phase, which is that bit a bit further. As the patient coughs, don't race to take that tube out. Let the patient settle. It's obviously a little bit uncomfortable. Let them catch their breath. Allow them to cough. Coughing is good, and it will help force those secretions higher up so that our suction catheter can get them higher up in their throat. Put your suction on, and nice and slow and steady withdraw the suction catheter. If you need to linger to make sure you're clearing the secretions, do so. So the patient still has another patent nostril and their mouth to breathe from. Come up nice and slow and steady. If the patient does have a really big strong cough and actually the secretions end up in the back of the mouth from this point, you can always detach the nasal suction catheter and reattach your Yanker suction, and then go into the mouth and clear the big bits of phlegm. You can then revert back if necessary to the nasal suction and continue coming out and removing. Single use, so you'd normally wrap and dispose of. Re-auscultate if necessary, and redo the treatment again as necessary. With regards to oxygen on a patient when you're doing the nasal suction, if they've got the nasal specs on, then that's fine. You can remove them to one side and go down one nostril. If they've got a face mask, you can still keep it over the mouth so they're still getting the oxygen that they're requiring. Obviously, if you can monitor them on a SATS machine at the same time, that's good